of a Zoom recording, just for those who aren't going to be here, is this book is recommended. At times I'll recommend the chapter. It's not mandatory, but it's a nice thing to kind of go through to get a sense of the differential process and that we'll be using within this course. Within here, if you want to find the Zoom links are right here. So if I click on this for the weekly meeting, you'll see that this is the link to get to the Zoom meeting on your own. So if you forget it, don't know where it is, you can always come back to this page and come to the Zoom meeting for these Thursday meetings. I'm going to come back here. Discussion board. There's a discussion board, and this is where if I go to the discussion board, I can post questions. So there's multiple participants in mine, but you may not have to do this one, but I'll go to Chicago 2025. And here is the discussion board of topics. So if you have a question for me, something you want to put out to the group, you can go into the discussion board, click on add new topic, and put in a topic right here. I will type in test. I think some of you received the email, some of you did not. So I go in there, type test, go advanced. It puts a 30-minute delay on your email. So if you have a change of heart, then you get a little chance to do it. Or if you misspelled something, you always get a chance to get back and do it. So I'm going to take away the time delay, post to the form, and you guys should get an email immediately without the time delay. So discussion board is a good place to have questions. If you have sometimes technical questions, feel free to email me directly. It might be a little faster way instead of emailing everybody something that you need from me. So I'm going to go back to the 25 course up there. Program outline. You know, we've talked about condition scripts, and we'll talk about that a good bit today. We'll get into that a bit, and illness scripts and the model that we'll use. There's a glossary of terms here, which can be helpful because in the world of manual therapy, there's a fair amount of just vernacular that has been different. Some of this has been passed down among different groups and generations. So this glossary of terms is kind of nice if you're going to go through it or you see an abbreviation such as a PIVM or a PAVM, you're able to kind of move through it and see. So glossary of terms is there as a reference. Final exam, I'll close that up. That's the final exam we used in the last group. I just haven't closed it up yet. So if you want to go there and take the final, feel free because yours will be updated. So have fun. The files below here are just the raw files sometimes that'll be available to you, and you may see them or you may not. These are the files that will be linked up in here. So where we'll be living for the next 4 weeks is going to be in Module 1, Assessment and Treatment of the Lumbar Spine. So in here we have pre-course Zoom session prep outline. Typically, most of our outlines and our run-ups will be 6 to 8 weeks of content. Now we're a little short on this one, and the first one often is. You know, it's a little shorter run-up, so we've abbreviated a bit, but you're not going to lose any information. That's the beauty of a long program. We're going to be able to really cover it well over time. So I'm not worried about the shorter run-up, and I don't want you to worry about that either. What you're going to see here is I've organized it into 2 sections. On the left-hand side is the self-directed study. These will be the short videos that we have covering a topic. Many of the first ones are done by Jim. And then on the right-hand side, it's just a quick outline of what we'll be discussing in that Zoom session, covering that material. Sometimes we will cover those videos exactly. Other times the videos are going to be complementary material you need to know, and we're going to cover a topic close to it, but slightly different to get into some different material. Where we've used this platform is that we've been able to take a lot of the didactic from the program and find what can we deliver here in the didactic so that when we're together on the weekend, we can really work on this hand skills and manual therapy, the lab time of working on skills. Can we reduce some of that lecture time so that, you really get a chance to practice because you feel it over time that, when I get to those later modules, I'm like, I really feel like, man, I only have 2 more sessions with you. How good can we get you with your hands and with your skills in that period of time? So this didactic portion is really designed to kind of make sure we can cover specifically this didactic material and allow us to have more hands-on time. And what I have seen with this is that this used to have a 9th course that would go along with this, with an advanced course. And what we've been able to do in this format is take most people in this 8-course modular system and get them almost through the 9th course material of the advanced manipulative techniques. So by using this format, we've really been able to kind of, really push the individual in this program much, much further along than we could, say, 3 years ago. So this is well worth the time. At times, again, it's a bit of a commitment, but it's well worth your time in the long run. And unfortunately, right now, you're gonna have to trust me on that one because you've known me for 20 minutes. First topic we're going to cover today is going to be, pattern recognition, hypothetical deduction, and script-focused deduction. This is how do we think? How do we think in clinic, and how do we frame our mindset to make a differential diagnosis? Next topic we're going to cover is going to be, really kind of some of these condition scripts. What are the common conditions that we see, and what are their presentations, from spinal instabilities to disc herniations and the various types of disc disruptions. And again, I created readings for this one too on different conditions that can kind of be complementary to the videos. And in this one, I put in a bonus track of another gym video for making the pathoanatomical diagnosis. As I said, we will be covering some of the material in the videos, but we will also be doing a more clinical discussion within the Zoom sessions is the goal. So we want to really tie back out that theoretical model to really talking about what are we doing in clinic. There's a dry needling track. We're not doing that in Chicago, but some of the cohorts have a dry needling track. So sometimes in there, you'll see dry needling articles and issues related. And that's just part of that other track. Selective tissue tensioning and force output. We're going to put a section toward that. And, how do we really use strength testing? Hey, Eric, and differential diagnosis in that section. So in there, we'll be talking about it. Eric will do a good bit on velocity dependent weakness and the different types of weakness. And you're going to find that as we look at these tests, it's not just going to be about strong or weak. It's going to be about the quality of contraction and speed of contraction, wearing a lot of information. And on 30th, that Zoom session will be on this topic. And again, in here we have suggested readings that have been pulled out and the presentation. And then right before the clinic, we'll do lumbar biomechanics. Now, lumbar biomechanics will be more segmental biomechanics, and then we'll get into more general, biomechanics of the lumbar spine as a whole. And that'll be covered more during the course as we get into it. And so these will be the 4 lead-up modules that we are going to do for the next 4 weeks. The other modules that were in there too that we'll cover, and I'll put out videos. There are videos on it, but I'll also put out some summary videos and some articles. We will cover this over time. We'll be differentiating nociceptive radicular and neuropathic pain. It's an important one. These are great articles that came in the last couple of years, just really kind of clarifying those differences, because that is certainly the first thing I do when a back pain patient comes into my clinic, and Eric probably the same, is that they have back pain, but I want to know as quickly as I can what type of pain they have, because it really dictates a lot of the pathway of what's about to happen next and what I'm seeing. So these sections of self-reading, very worthwhile in doing, recommended. We will keep coming back to this throughout the program. And that'll be one of those things by the time we're done, it's going to be automatic. It was automatic in the last group, Eric. I thought they did great. I couldn't ask them a question between there. They couldn't differentiate. And that really helps frame where you're going. Another topic in there would be unraveling the mechanisms of manual therapy. Now, this is an article where I don't necessarily agree with everything in it, but it's great to have in there because it talks about the neurophysiological mechanisms of manual therapy, of how manual therapy modulates pain. It doesn't differentiate between manipulation, mobilization, dry needling, an instrument-assisted soft tissue mobilization technique. Many of the brain pathways are fairly similar in how we modulate pain. So this article does a nice job of summarizing the effects of manual therapy. And this is why manual therapy really came back into vogue in the last clinical practice guideline, where I'd say, 10 years ago, it fell out of favor to a degree. And then it came back really based on the pain science research and the pain modulatory component, where they may downplay the mechanical aspect of manipulation, mobilization. I think they underplay it. And we'll show you why basically over the next 16 months. So don't agree with their assessment of it there. The pain modulation stuff is good. Again, we'll get into motion patterns too. We talked earlier about there's the biomechanics of the lumbar segment. What is L5 doing on S1 or L4 doing on L5? And then there's the summation of how we move as a whole. And that's where you really get into the different models, whether you're looking at a McKenzie model or something from the movement system impairments or Shirley Sauerman to Peter O'Sullivan. There's different schools of thought on movement patterns and movement pattern dysfunctions. What we're really going to look at is what's the unified theory between all these? How can we as practitioners use a clinical reasoning model where we're not necessarily strapped to using Peter O'Sullivan's model? Like we don't have to be there. We can blend in multiple people's models to integrate the best treatment plan. And that's really the true purpose of this. And Paul Hodges and some other researchers speak to that. Is our goal is to really kind of blend multiple schools of thought from multiple different approaches into a unified model. And if you really want to kind of summarize what we look to do with this, that's kind of what we look to do with that. Eric, any thoughts or any input on the model that we like to put forth?
Honestly, I think when we think of using a model, it's more of like you don't want to call it a system, but there
Mhm.
is a certain systematic approach to going through things and being able to get from point A to point B to whatever the diagnosis and treatment method will be. But basically the idea is if something works, you can use it, right? So I've taken courses from all kinds of people, from osteopaths to chiropractors and all kinds of random things just to get different perspectives on treatment and whatnot. And I'll take away at least something that's useful from pretty much every course I've ever taken. Um, the idea here is that if you can take those pieces of information from whatever it is that you're learning and put it into a system that you're capable of using consistently, it makes you much more efficient, it makes you much more effective. And so that's the thought process behind this whole program, is that we have kind of a system that we've been using for years and years. But anytime we find something that does have some criterion validity to it, meaning it functions the way that we look at things anatomically and biomechanically and whatnot, then we can kind of take that and insert it into the system that we use and say, okay, how does this fit into the headspace that we're in when we're trying to go through a process of looking at a patient? So I think Dave's totally right. I think the idea is not to discount things because it comes from a specific source, but be able to look at things critically and decide whether or not it's something that's going to be useful for your method as a therapist.
Yeah, and that's
Long,
always the
long way of
hardest
saying I
part.
agree with Dave.
Yeah, hardest part of this program initially is that it's so much coming at once because you're trying to blend all these models that in the early going, the first few modules, it's hard on people because there's not a unified theory. But then once you get to 5 and 6, the unified theory starts to come together. We'll always try and tighten that up, see if we can do a better job than we did last time. But it's typically because it is such a broad topic and everything that we're covering that it takes a little while to build that. Okay, I see now how this all interrelates. And I see the full picture because we're teaching it to you in pieces. And you always want to see the full picture all at once because it's the way we're wired. And I am no different. Just scroll back up to the top here. So where we wanted to be kind of today, and if we're not there, that's fine. You can take some time. What I would strongly recommend is where we want to be today and prepping for today is that as you get in there, you'll see in the self-directed area, there's generating the initial hypothesis. There's script focus, hypothetical deduction, two about 50-minute video presentations on the topic. Today, Eric and I will kind of dive into a bit of pattern recognition, hypothetical deduction, and the concept of script focused deduction. Really introduce the concept of how we want to start kind of thinking in clinic as patients come in. As I did a little bit of this today in clinic, is I often tell people when that person's sitting in the lobby and I get a piece of information, I already start formulating what my H1 is likely to be on that individual and have a good sense of where I'm going to go and what my first two meaningful questions will be, not the ones that develop rapport. So let me jump back one screen real quick before we go on with that. To be below here is just for those of you, if you can't get into the Google Doc, I built it into a site there and the videos will be here. So if you want to go to this section here, the videos and the readings are housed on the Moodle platform in there, and you can toggle basically through them that way. So on the home page, that is the lumbar page that's there. I'm going to upload the 2025 manual. Coming up, I'm going to go through it real quick and just make some updates. You want to see the hour by hour for course lab, it'll generally be the same. So the hour by hour course lab, what we'll be doing will be there. The skills list for module 1 will be all the skills that we are going to cover during module 1. Oh, wrong one. I will upload the correct one there. So I will upload the skills list for module 1. Those are all the videos from Jim. So I will update that link, and that'll be this thing. So if you want to go in and see the video technique for this technique for assessing the pivot and pablum of the thoracic spine or lumbar spine, it'll be in here as well. As well as I'll have the links in the manual. So when you're viewing the PDF manual, when you get to a certain section, let's say we're at 2 o'clock on a Tuesday or 2 o'clock on Saturday, you'll be able to click in the manual, look at 2 o'clock on a Tuesday, and the techniques we covered will be in the manual, and you can click the link in the manual, and it'll take you to the techniques that we did at that given section. So these skills lists will also be linked in the course manual. And down below is just all of the normal final quiz, faculty assessment, and course assessment stuff to get a certificate. So that summarizes kind of what we'll be working through in the next 4 weeks here. In the next 3 weeks or 4 weeks, we'll be focusing on the pre-course prep as the major component. Let's see if I have it back here. Right, we go back and saw a question or if you're trying to log in, then what I will do, Brianna, is I will look and see if they put it, I have in the correct login and password, and after this meeting, I will adjust it. Make sure you're in there, and I can log in as you as well. So your homework is to go back and do the videos if you haven't seen them. I'll get you, my homework will be to get you logged in. Good, yeah, just put in there if you're getting an invalid login. I will go and check that on my end. Sorry, just kind of moving through some files here. Same with the Google links. The Google tab should work. If you bump into a problem, just let me know. I think I have them all open and set correctly this time around. It's a good one. It's always a good time to torture Michelle. You know, pattern recognition is the first topic we really want to kind of go over, is how we think. You know, we're going to look at is the concept of pattern recognition, hypothetical deduction, and then, you know, we're looking at the concept of script focus deduction in here. And we'll kind of work through these a little bit. You know, pattern recognition is what you think of as an expert using. It's, you know, this is where the experienced clinician, it's fast, it's intuitive. The clinician recognizes the similarities between the current case they're seeing now and the previous cases they've seen. They've built up this, you know, this volume in their mind of what the typical case looks like when they see this condition. You know, ideas like this is considered forward reasoning, being that, okay, you already kind of know what you have, and then you kind of proceed from already knowing a point of reference. Example for me may be that, hey, I get in the patient history, a 36-year-old male presents with numbness tingling down the right leg into the lateral foot. First hypothesis. So like, okay, Michelle, you're the pickle in person today. Michelle, H1 on that history.
Posterior lateral disc herniation.
And what makes you think that?
The referral down the leg, the numbness, the tingling, his age. It's kind of consistent.
So as we see this, we already start formulating an opinion based on what we're seeing right here. Would you have an second hypothesis on this one? Like maybe like, okay, if this one doesn't work out, what would be a second likely one?
Segmental dysfunction.
Yeah. So that's the idea that I have something in a joint maybe doing this because patient may come in and they may present with numbness and tingling, but that's in their history. You get there, it's really not. Let's say it's just a dull achiness into his buttocks. or not something non-specific in the foot, that could certainly change that presentation. But the H1 is that, what do I expect to happen? Michelle, can you explain too, as you've done this, how did that impact, like, how do you set up your evaluation or your next step with this individual?
So you'll kind of just get more and more information as you go along with the subjective that will kind of confirm your H1 or potentially switch, like your H2 is now your H1. And then that will guide your test and measures as far as to either your kind of correction bias to confirm that, hey, it doesn't sound like this. I'm going to do a test or two to make sure I completely rule it out. But also mostly like to use those tests and measures to confirm your working hypothesis.
Yeah. So from this method, what you end up doing is, like, as you said, my initial questions are going to be focused on ruling in first, do I have information that strengthens that this is a posterior lateral disc herniation that's irritating the nerve root, or I have irritation in the nerve root that's causing these symptoms, and that'll be like that pattern. So my questioning and my test will be specific to that. I mean, an example of this may be that, okay, if you're looking at special tests, it's going to be a straight leg raise. It's going to be, okay, do I have diminished reflexes, or, pain with posterior to anterior pressures may confirm it, but there's a lot of things that can be painful with PA pressures. So in my mind, I want to have, what does that disc herniation look like? And this is kind of where the illness script model comes into hand as we look at hypothetical deduction. We'll kind of go over that a little bit later on, but that's what we want to think about as we do this. It's really about, having an idea of what is the typical presentation of the typical cases we see, and having a clear imprint of that in our mind so that we can base our examination and questions on that topic. This process, it really does rely on prior experience and knowledge. So we want to work throughout this program to build our knowledge base, to expand what our scripts are of different conditions, so that we can better or more readily recognize these things. Because these are matching familiar things we've seen. I think, as you see here, another example is that therapist that recognizes this as a posterior lateral disc, the radiating leg pain, the significant loss of function. This person has a hard time doing things. They're missing work. They are severely limited, and pain would be severe in these individuals. The advantage of pattern recognition as you develop it is basically it's fast. You're going to come to your diagnosis fast, and it minimizes the need for complex problem solving. There's less time in this cloud of figuring it out, and more time in getting to the point of, I've made a hypothesis, I'm able to test it, my tests confirm that this is my diagnosis, and now my examination comes into being bias correction, making sure that I didn't miss anything, but then also looking for, what are the contributing factors? What are the things that caused this pain pattern to happen? Is there something in the hip? Is there something in the thorax? Is it the way they move? Do they have a flexion dysfunction or extension dysfunction going on that's stressing this? So we're going to look for this. That's the advantage. It allows more dedicated time to research the contributing factors. Again, disadvantages, reliance on experience. If you're not experienced, it's hard to kind of get it. I'm choking here. All right, Eric, do you want to take this next one so I don't hear choke through this portion of it?
Where are we at here? I was typing something.
Yeah, no problem. Hey, just think about bias correction during this process.
Yeah, and that's kind of what I was typing about. The biggest thing the biggest complication that we can run into as clinicians with the script-focused deduction, basically, as we sit and we say, somebody comes in and we're like, okay, this looks like a disc pathology. As soon as we start anchoring to a diagnosis, we take away the possibility that we may run into an outlier. And those things happen all the time. So for instance, if we have somebody coming in with the presentation that Dave gave us, somebody with, numbness, tingling going down the right leg, the first thought we usually will have is, okay, this looks like a disc. But in most cases, those disc pathologies will get worse with flexion positions, right? They won't want to sit, they won't want to bend forward, those sort of things, because it tensions that nerve root, that irritated nerve root over the protruded disc, over the damaged disc. But what if we have a patient that comes in and sits just fine, bends forward just fine, but is worse with rotation moments of the spine? We could be dealing with something that suggests a pars fracture or a neural arch fracture. Okay, because the nerve root goes right underneath that component of the bone. If we fracture that tissue, we could very easily get inflammatory pressure, inflammatory irritation of that nerve root, right? So we have to take into consideration that there are outliers out there that have to be a part of our diagnostic process. So looking at bias correction is something that we will always tend to do, because you don't want to be the therapist that just has this kind of umbrella, right? Where somebody comes in and they kind of fall underneath that umbrella, and you're going to say, I'm going to jump right into the process that I go through. So I've worked with therapists that are like that. Hell, when I came out of school, I was a therapist like that, right? Where somebody comes in, they say they've got knee pain. And I did the exact same thing for knee pain for every patient that came in the door, right? Somebody comes in with anterior shoulder pain. Okay, automatically I know what I'm going to be doing. And that's not the case, because we do need to know what tissue is damaged, and we need to know what caused that damage in the first place. So bias correction is an important thing. Um, like I said in the little thing here in the chat, is we do tend to see the most common things more commonly, because that's why they become common in the first place. But being able to look at something and say, okay, there's this component of this that's not matching up to what my typical script, illness script would be for this particular pathology. What else could be causing this issue, or are we just seeing some sort of abnormal presentation to this? So that's the whole idea behind bias correction. And it should really be a part of all of our hypothesis generation, right? So the idea is that somebody comes in, the H1 is kind of your most common problem, right? It's the thing that we say, well, this looks the most like this particular hypothesis. H2, like Michelle said, would be maybe, okay, here's the next most likely thing. So disc pathology, then segmental dysfunction, then maybe instability and or stenosis, something like that. And then maybe down the line is something, more medically based. So what we call a null hypothesis, something that doesn't necessarily require physical therapy intervention. It's more of a medical problem. Or something that's, just the percentages, the probabilities are really low, like maybe a peripheral neuropathy of some sort that's presenting in an abnormal manner. So being able to look at those things and say, okay, here's the tests that I would do to confirm my H1, right? That would set me up and say, this is the cluster of things that I would see with H1. That's going to be that's going to be my answer, my diagnosis. Here's where I can go looking for my etiology, which would be the thing that caused the tissue damage, right? So for a disc pathology, maybe something simple like they tried to lift something too heavy out of the trunk of their car, right? That could be the etiology, the cause of the problem. But yeah, I mean, I think if you can get to the process where you can say, okay, now I'm comfortable saying H1 is my true diagnosis, you want to rule out some of these other things by maybe doing one or two tests. And we'll show you guys lots of screening tests and things of that nature. Screening test being something where we can look at it to say, very briefly, this body region is not involved, right? So it's a quick test, something and say, okay, if this looks abnormal, we need to go in and do a deeper examination there. But it's really easy stuff to do. But we definitely want to make sure that we're not looking at things and just anchoring onto the first thing that comes into our head, because that can oftentimes lead us to the wrong treatment method. Hopefully that all makes sense.
That's the idea with the scripts is now like part of your bias correction there is like, okay, well, okay, this looks like a disc herniation. What does my illness script for, lateral stenosis look like? Does this match what I'm thinking for lateral stenosis on my test or a segmental dysfunction? You can then test your other scripts because those would be the other competing diagnoses. So as you go through your evaluation process, you're kind of ruling out these other conditions in favor of the condition that, was your H1. So you're looking at your evaluation a bit with a bit of purpose. So I'm looking at range of motion and muscle testing and everything else. I can then cleanly say that, hey, I'm not seeing these other things as being the primary one. They're in the Bayesian theory, their likelihood is dropping down based on my examination findings. So that's why in this process, and that's where this goes sideways, if you're always solely relying on pattern recognition without self-reflection or a form of bias correction, because you can then kind of, fall victim to confirmation bias and these other biases, but built into the process is that ability. And then as you do it over time, you get more and more refined, knowing the typical presentations, you can identify them faster, and then you start to develop pattern recognition. hypothetical deduction it's basically it's an analytical process where the clinician generates multiple hypotheses and tests them through further questioning, examination, and testing. And the idea is then backward reasoning, working it the back way. So I don't know that I would actually think they're backward and forward in that sense. Now, where we modify this a little bit, instead of saying, hey, we have now my 5 major diagnoses, I'm going to test them all at once. What we're doing is we're identifying one as our primary in hypothetical deductive reasoning. And we're going to focus on what we think is the most likely first. And then in our examination process and our search for etiologies, we are now taking our other hypotheses and testing them against what is the primary. I think this is a disc herniation. As I test and do my examinations, is there information that's then ruling out the likelihood that this is a hypermobility or an instability, or that this is a subluxation or a cauda equina syndrome? Our examination then should strengthen our hypothesis and take those other competing hypotheses and drop them down the list. And that's the concept of using script-focused deduction. What is the typical presentation for the most common cases that we see, and understanding them really, really well, which will then allow us to identify the many outliers that will exist within the norm. Because there will be many outliers, but once you have the idea of what is the typical pattern, the outliers stand out more, and then the outliers are actually easier to kind of work through because they aren't as perplexing. Because this is an atypical, lumbar instability or atypical subluxation or an atypical posterior lateral disc. I'm then able to kind of work from that platform. So, this simplifies it. Idea script focused deduction really simplifies the reasoning process to focus your vision on one hypothesis at a time with several questions. Jim recommended there should be 4 questions focused on this condition. And then you want to pick your best tests. And we'll work on this during the labs is what are the 2 or 3 best tests to rule in or rule out your hypothesis? Which ones have the best sensitivity or the best specificity to strengthen and confirm it? And then in your examination and bias correction, those special tests for those other conditions may come into play to kind of rule those other ones out as well. So that's it. Once your hypothesis is confirmed, now your examination then focuses on, hey, let me search for etiologies and perform my bias correction. And that's where it gets fun, is looking for, can I find these contributing factors that may do this? Where we'll get into is, hey, how does, I have an ankle which is subluxed and won't dorsiflex, and I've lost end-range dorsiflexion. How is that creating an extension hypermobility or an extension problem in my lumbar spine? That is when we talk about search for etiologies. More closely, it could be that I have somebody who's lost the ability of the right hip to posteriorly glide, so I've lost that extension internal rotation moment, and that's creating an L5 S1 subluxation or hypermobility. And that's that search for that etiologies. So when we can develop a hypothesis and test it efficiently, then our mind can switch those gears into that, what are the things that I can find out there that may have caused this issue? And that's really the hallmark of the program by the time we get to those later modules, is to be able to say, hey, I can work from the ankle up to the lumbar spine or thoracic spine, or even at that point, I could look at the hip and pelvis and, maybe see the dysfunction that's going on up in the cervical spine. And, this is the process that we'll be working through, but the very foundation of it is being able to develop the script-focused deduction and the reasoning for the most common cases, and then be able to build from there. Yeah, and so these just give you a couple of different examples of cases of, okay, what are the typical ones you might see? Again, we have a 36-year-old male with lumbar pain that's moderate in nature and refers into the SI joint and gluteal region. And he's able to still play pickleball, and he works at Giant in a grocery store. You can see this pattern here. If I see this as my initial history, it's not somebody who may have a posterior lateral disc. He's fairly high functioning. My H1 on this one may be a segmental dysfunction until proven otherwise. So when I looked at this patient, I will be thinking this patient may be a segmental dysfunction. My initial questioning line will go toward that idea that this person may have a subluxation of one of these joints, or is there some type of irritation or disruption from a movement pattern? And again, if all of a sudden we see that he has calf weakness and paresthesias or numbness into the lower leg and lateral foot, I'm now going to probably have to alter my H1 to consider a a posterior lateral herniation or a disc. So within this process, it's not that we can't change our H1. We should change our H1 as soon as information tells us that, hey, he looked like he was going to be somebody's going to be a manipulable lesion at L5, but hey, now I'm getting information telling me otherwise. So we want to kind of move on from this differential.
Yeah, and you guys should really, a lot of times one of the major things that people want to do when they get into this program is they want to be perfect with their H1s all the time. And just say the first hypothesis that I have is going to be the correct one, because you think that's what we're looking for out of you, but that's definitely not the case, right? The idea is getting to the right answer, rather than always having the right answer right off the bat. So if you have to say, my H1's not looking good, it's looking more like my H3, or hell, even if you get into a situation where the actual hypothesis that you should be testing for isn't in the original list of hypotheses you had, that's okay. That happens to me all the time. I'm sure it still happens to Dave at times. It's just one of those things where you want to be able to use this method to get to the answer and be able to do it without throwing out, 30 different special tests or doing too much stuff that's going to give you mixed results. And that's one of the things that I always had problems with when I was a young therapist is you come out of school and, for example, the shoulder region, we must have learned 50 different special tests in PT school for the shoulder, right? And some of them for rotator cuff, some of them for labral pathologies and all these different things. You do all these tests, some of them are positive, some of them are negative. All they do is confuse you. So being able to use reliable tests consistently and do them properly gives you a better idea of what you're really looking for, rather than throwing the whole world at it and saying, well, I did these 10 different things and each one of the 10 has given me a different answer. That's only confusing the situation here. So being able to use the system to get from whether your H1 is the actual answer, or if it's, H6 that you might have to come up with after the fact, after going through some of this exam process, it all works. So don't get so hung up on trying to get H1 correct every single time, because I do see that quite a bit.
Now it's not a judgment on what you do. It takes more strength to change your H1 than it does to stick to it. That's the part of bias correction.
Yeah.
And that conflicting information. I mean, I had a case last week where, it was pretty routine. Guy came in, tennis pro, he was playing. He noticed some, numbness in his right calf, and he noticed some weakness in his calf as well. So he stopped, he got a little concerned, came in to see me, and again, look at him. Scribes his areas, numbness had kind of receded, but you can tell his calf was weak, and it's vaguely weak. I don't necessarily call it necessarily fatiguing. It was kind of consistent in there. But this is my first one. It's like, okay, this sounds like 36-year-old posterior lateral disc. He's had something go on, but he had no back pain and nothing else going on, which was kind of odd to me. So I would expect him, knowing he's during tennis, that I was expecting to see some type of somatic pain, maybe coupled with the neuropathic or the neurological symptoms. So, okay, heel raise is weak, and then I go in to do reflex testing, and he's hypertonic in his reflexes. So now I have somebody here who's hypertonic in his reflexes. He's got some autonomic sweating going on around his leg, and he's got calf weakness. I need to change my H1 pretty quickly on this person, because what I shouldn't have with a posterior lateral disc is somebody who's hyper reflexive and also has it's funny, it was like a 3 to 4 beat clonus in the foot with a posterior lateral disc. Those are upper motor neuron signs. Those aren't lower motor neuron signs, which would be indicative of posterior lateral disc. So I went from a very easy case and an H1 into something a bit more complicated. And again, I had no problem changing my H1 when the information did not support me. That's an atypical variant, but I knew immediately what the typical case was, and this was not the typical case. So I had to go a little bit further with this individual. That's an example of how changing H1.
Not only that, it changes the entire body region you're looking at.
Absolutely. That's a whole body screen.
All of a sudden, the lumbar spine goes out the window.
Yep, this was not lumbar. So it's like I knew immediately. It's like I went completely away from the lumbar spine to, okay, I have something much higher going on, and where to go from there. And that was everything from a cranial nerve screen, which we'll do in module 2, ocular screen, upper motor neuron testing in the upper extremity, you know, we did the gamut because this could be multiple things at that point. But not to get into it too deep, but that's where I started off with the typical case, and understanding the typical case, I very quickly understood this was not the typical case. And I kind of go where I go. And that's kind of where we want to be there so that we can recognize these, but then we can move on pretty quickly. And luckily I didn't suffer from anchoring bias with this individual. Again, in here we summarize just kind of some of the differences between these two models. We are working toward developing pattern recognition with a very good method of bias correction. And the process we're going to do that with is going to be through hypothetical script focused deduction. Jim tried to switch the wording to abduction a few years ago, and I find it confusing because no one else uses it. It is technically probably more correct because deduction by term means that the answer is 100%. And we're not always 100%. Abduction leaves that wiggle room that we're probably correct in most cases, but it's not 100%. So when you hear Jim mention abduction, that was the shift in vernacular that he made. I've stuck with, when I talk about with the word deduction, because it's more consistent with what you'll read in literature and maybe less confusing to you and me. Again, what we're looking to do here, as we talk about later on here, is that idea of working through these models to develop a system close to pattern recognition. Staying educated is a key thing. Reflective practice is key. There should be a time where you reflect on your practice, whether it's during the writing up the eval, whether it's right after the case, whether it's the next time they come in. For me, it's my drive home. I got a 30-minute drive home. So many times I'm going over in my mind the cases that I may have seen that day and thinking about it. I'll come up with the 2 things I forgot to do, and I'm okay with it because I'll get them next time. But me reflecting on it, thinking, man, I really should probably have looked at this a little bit more. Maybe I'll do that next time. If you're not doing that on a regular basis, then you're kind of leaving some chips on the table. So reflective practice is key. Take some time to really think about your cases a little bit as they come in and challenge your thoughts as the patient comes in, and even just retest them. Collaborative reasoning. I like to have other people even see my patients or look over my shoulder because many times it's like crossword puzzles. Being the person looking over the shoulder, it's easier to find the word than it is being the person holding the paper. And early on in here, we're going to have checklists. That's our script focused deduction, is having a checklist, incorporating clinical practice guidelines and using that information to help in that deductive process. Clinical practice guidelines are not our deductive process. They help guide our deductive reasoning and our clinical reasoning process. Much like treatment-based classifications give us a schema for things that may be effective with certain sub-patient populations, but our treatments plan should be much more sophisticated than that. So those are pieces of information that we use in our reasoning process. They are not strict Bibles that we should be following by fitting everyone into a certain category. And you'll see that pretty clearly once we get into this. So if you are currently using a system or you're kind of really have a model, I'm not saying don't use your model. I'm just saying that, hey, keep your mind open and we look to hopefully expand your model, make it stronger. Anything to add there, Eric?
No, like I said, I mean, I think the earlier you're on you are in your career, the easier it is to accept some of these things, because people tend to they tend to get comfortable with what they've been doing, with the things they've been using, the tests they've been using, processes, all that sort of stuff. And sometimes I do think there's some complacency that comes along with that. So just like Dave was saying, try and keep your mind open to the possibility here and look at the different things. And hopefully what we'll be able to show you guys when we get into the on-site courses is we'll be able to show you how these things work, right? So if we say, okay, watch how this moves, and then we'll try and do something to kind of change these things, we can show you how consistently we find these results, and that's why we continue to use them. So hopefully that kind of buy-in from you guys will be something that you can really get into, especially here coming up into module 1, because everything's new. There's a lot of different terminology, a lot of different things, a lot of different concepts that we're trying to get out to you guys early on so that you can get used to them. But yeah, I mean, I think if you guys are comfortable with giving the system a shot, giving these processes a shot, you'll find very quickly that they do work very well, and they will make you more efficient at the very least. And certainly practice over time should make those things more effective as well.
again, down in here, I put in there like the condition scripts, integrating them and what the model look like. And that idea of having focused questions and, trying to figure out two tests. It's the idea of minimal information. This has come out of a lot of different things. It's certainly used in decision-making grids. And they looked at this, I think it was Malcolm Gladwell even wrote about it. And I can't remember which one of his books, but just how, you look at it in the ER and fast tracking people, I think it was with chest pain. By simplifying the process, they were far more accurate and got far better results than kind of being very broad in general in it. And it trickles into that mindset of sometimes the more information we get, the more confounded we are. So when we're looking at typical presentations, if we focus our questions on, okay, I'm going to test my H1 and I have my couple questions, my couple tests, and I can focus on that. And okay, now this is a fairly strong possibility because these are all positive. Then my bias correction goes into my full exam. I'm much more likely to come up and feel and be stronger about what I find. And again, if the information is conflicting as I do tests, then I deal with that as it comes on and I change my hypothesis. But this really helps to refine it versus the model of let me collect every piece of information I have, let me do every exam, and then at the end sift through it. We really want to kind of this process focused. And again, I don't expect you to do this tomorrow. This is something that we're going to work on developing over the next few weeks and months. Again, here's a typical diagram in here, and you should be able to kind of blow this up or print this out. And this was kind of from Jim, and this kind of describes pretty simply and consistently what is the typical presentation of different conditions. And what Jim encouraged you to do is to kind of also create your own and look at your own illness script and how they match. Many of these things, those of you not familiar with the term segmental dysfunction, you can think of that being as kind of a biomechanical problem that's going on. So over in the lumbar spine, you're looking at, basically here, probably a joint subluxation or something that has been jammed at an end range. But within there, you could probably include the whole spectrum of what you may see from a hypermobility or instability to the sublux jam joint. And we'll talk about end feels of joints and the different meaning of different end feels in a future Zoom session prior to the on-site to really kind of help focus our mind on when we feel something, what are we actually finding with that? But it's a good one to print out. I printed this out even today because I was going over this for the people in the clinic where I was to go over and say, listen, this is kind of where we want to be by next week is we want to get a good handle on these different differentials and then start to develop our own. But again, always knowing that these are the typical presentations of the classic cases. And you will see tons of variations in presentations on these different cases, but this gives you a solid starting point to then start to find the outliers. I know. And again, hopefully this isn't too all overwhelming at once, but the one thing is that's why we record it. I'm going to post it in there online into the Google Doc. You can come back and view it. And again, we have the discussion board and we have places, but don't feel like you need to understand all of this or have it all down pat immediately after this. This is what this whole next 6-week journey is about, is really kind of refining this process and building on this process. And we're going to revisit this multiple times throughout the next 16 months. Cool. So we talked about it there. Actually, let me go back and share one more time as we finish up. Share the screen. Go back and go back into course prep. So as you get into there, course prep will be covered basically. I just went over the suggested reading. What we're going to be doing next week is going to be condition scripts. And there we have the presentations, the short video presentations from Jim Meadows on segmental instabilities and disc herniations. Later on, we'll have a segmental dysfunction one. I put it down, I think, in week 4. Reading, I created similar reading summaries as the disc pathologies and spinal instabilities. Now, Eric and I will not follow this reading format where we go off this reading list. We will discuss more freely in a case style format in future sessions. I just thought it was helpful to have these written out, and we will cover some of these topics as we go. And we're going to work on script focused deduction. At times we'll also go through cases, but it'd be good to kind of have a clear understanding of some of these different concepts, the concept of instability, understand the different types of disc herniations, and go from there. Cool. As I told everyone else, if you did not get the initial emails that went out on Monday or Sunday and Monday, then email me or I put it up here on the discussion board and let me know. And I will get it. If you're having trouble accessing the course prep document saying unauthorized, I will go in there and try and I will see if I can, if it's a link issue, and update the link. If not, it is in Moodle. So if you go into the Moodle right underneath of it, I've uploaded everything into those pages there, which will be Zoom prep on site there. That will take you to all the presentations. So if for whatever reason the Moodle link is not working for you, you can access all that information right there on the page. So I try to make redundant resources because when links fail me. And again, I will see if I will reload that Google link and see if it's a access issue there to get it up there. But again, all this information is on the webpage in the link right below it, and you should have the access to the videos and the Google Docs right there. But right after I finish here, I will do that. Again, I will go through here, but that said, I am all finished. Good. If you haven't received the email, as I said, give me your email address and your name in the chat area, and I will go back and I will recheck it in the system to make sure it's correct in my system. I think there may have been a firewall issue sometimes within the Athletico system, which blocked it. Since I sent out an email with multiple links, you may have gotten firewall.
So, Dave, I have a question. So, if we can get into that impact with our login, do you want us to change that email from our Athletico to a personal one?
It doesn't matter. You can, because I'll go back in. I'm going to go back in and recheck everything. It's like we're pretty careful about how we enter people's names. I just want to make sure that, okay, we entered your name correctly. And there's not an error somewhere in there where just you go to type in your password, and because I didn't put 2 R's in your name, it didn't take it. So that's what I'm going to check right now, just to make sure on that end it's good. If your information is all correct in there, then again, I don't think it will be. I think I'll be able to just reset it and send it out to you. Let me recheck my list. Yeah, because I didn't have you on my list. Or Jacob. Was that you, Jacob, or was that David?
I'm able to get in. I just asked the question if you wanted us to change it.
Oh, it sometimes is handy. If you can get in, you don't have to.
Okay. It was just for the links that you were talking about with that firewall. I was just wondering.
Yeah, if somewhere you're hitting the firewall, then that may be the case. But and then it's entirely up to you if you prefer to get it to a different email. I will kind of send out some things here and there on the weekend, but again, it's not like you have to. Nothing I send out has to be done right away. It's just more reference for you. But I will go through these links. My email, you should have. I'll put it here. So if you want to email me directly, there's my email for those of you still hanging out. Take that, email me directly if you have any problems, and I'll get you sorted in short order. Because I know this first week is always a bit of a painful process between getting the links sorted and doing things. And some of that's just the technical stuff with Athletico. Some of that is honestly just, my lack of aptitude with computers as I reach my declining state.
Steep hill sometimes.
Yeah, it feels it. All right, good people. Next week, good prep. This is gonna be good. This is gonna be a good experience. Keep going. You have questions, please feel free to ask me. I will send out some cases here and there just for fun. You can kind of go over and we can chat with them a little bit too. They're real mandatory. Good. Other than that, I am done.